Good day everyone, my name is Blanch from Section B and I am with Ms. Angel Delmonte from Section B. Today, we will be discussing ischemic cardiomyopathy, a serious and often debilitating condition that arises when the heart muscle becomes weakened due to insufficient blood flow. So in this presentation, we will explore its definition, prevalence, risk factors, signs and symptoms, diagnostic methods, and most especially the available treatment options.
The topic outline are the definition, prevalence, risk factors, disease mechanism, signs and symptoms, laboratory and diagnostic tests, medical and nursing management, surgical and pharmacological management, and then lastly the prognosis. And then let me identify each or elaborate what are the contents in each topic outline. In the definition and prevalence, this section provides a clear explanation of what ischemic cardiomyopathy is, and then as well as its frequency or occurrence in the population. This include the statistics, demographics, and groups most affected. And then in the risk factors, details factors that increase the likelihood of developing the condition such as lifestyle choices, the smoking or the diet, and then the comorbidities, the diabetes, and then the hypertension or the genetic predisposition. And then in the disease mechanism or in the pathophysiology, it explains the physiological or pathological processes behind ischemic cardiomyopathy. And then the signs and symptoms describes the clinical presentation such as fatigue, shortness of breath, and etc. And then the other indicators that help in recognizing the condition. And then in the laboratory and diagnostic tests, it is the outline of the tests and procedures used to diagnose this ischemic cardiomyopathy. And then in the medical and nursing management, it focuses on the treatment approaches in the condition. And then the surgical and pharmacological management, this is the intervention. It covers advanced intervention that we're going to use in the condition. And then lastly, the prognosis, it provides the information about likely the outcomes of the condition, the life expectancy or quality of life for patients, depending of the stage of disease and adherence to treatment.
So now, let's dive into understanding ischemic cardiomyopathy and its impact to heart health.
Let me introduce to you or define what is ischemic cardiomyopathy. Ischemic cardiomyopathy is a serious cardiovascular condition that occurs when the heart muscle becomes weakened and struggles to pump blood efficiently due to reduced blood supply. The condition is primarily caused by the CAD or the coronary artery disease, which leads to the narrowing or blockage of coronary arteries. Over time, the insufficient oxygen supply to the heart cause myocardial damage, scarring on progressive loss of function, ultimately resulting in the heart failure. And then ischemic cardiomyopathy is one of the leading causes of morbidity and mortality worldwide, with a significant impact on patients' quality of life. And then the prevalence of ischemic cardiomyopathy, it is recognized, this condition recognized as a significant contributor to heart failure cases worldwide. It affects approximately 1 in 500 adults globally, indicating that is relatively common, particularly in populations where coronary artery disease is prevalent. And then the coronary artery disease, which involves the narrowing, as what I said in the introduction kanina, it is the leading cause of ischemic cardiomyopathy, DCAD, or the coronary artery disease. In fact, ischemic cardiomyopathy accounts for up to 60% of all cases of cardiomyopathy, making it one of the most frequently diagnosed forms. And then the cognition predominantly affects males aged 50 to 70 years old, suggesting that both biological and lifestyle factors during these years contribute to its development. And then the gender naman. Ang difference might be explained by hormonal influences, lifestyle habits, or a higher rate of diagnosis of the coronary artery disease in men compared to women.
So hello again, let's now proceed to the pathophysiology of ischemic cardiomyopathy. Hypertension, smoking, diabetes, Unhealthy diet, sedentary lifestyle, obesity, dyslipidemia, and excessive alcohol consumption are modifiable factors for ischemic cardiomyopathy because they contribute to the development of atherosclerosis, increased blood pressure, and damage to the heart's blood vessels. These factors can be modified by lifestyle changes such as diet, exercises, smoking cessation, reducing the risk of ischemic cardiomyopathy. Age, gender, family history of heart disease, and history of heart attack are non-modifiable factors for ischemic cardiomyopathy because they are inherent characteristics that cannot be changed or controlled. Modifiable and non-modifiable factors upset the metabolic balance, leading to increased fat deposition. Excess fats, particularly visceral fats, lead to increased LDL or low-density lipoprotein cholesterol levels. Since it travels through the bloodstream, it contributes to plaque formation and creates mechanical stress on blood vessels as well as a pro-inflammatory environment, leading directly to the damage of the endothelium. After the integrity of the endothelial barrier is breached, the LDL particles penetrate the arterial walls, where they are retained and become oxidized due to reactive oxygen species in the subendothelial space. After the LDL undergoes oxidation, there is now the formation of the oxidized low-density lipoprotein. The oxidized low-density lipoprotein becomes a pro-inflammatory molecule which triggers an inflammatory response to activate endothelial cells and attract immune cells to the injury site. An increased C-reactive protein then appears because it is the product of an acute inflammatory reaction where it is released by the liver when the process of inflammation takes place. Inflammatory cytokines attract monocytes which differentiate into macrophages within the arterial wall. These macrophages recognize oxidized low-density lipoproteins through scavenger receptors and engulf them, transforming into foam cells. The accumulation of foam cells within the arterial walls forms fatty streaks which progress into mature atherosclerotic plaques. These plaques reduce the elasticity of blood vessels, impairing their ability to dilate or contract normally. This decreased flexibility increases vascular resistance, forcing the heart to work harder to maintain blood flow. The resistance increases the activity of sympathetic nervous system and thereby causes systemic vasoconstriction and high blood pressure. Prolonged vasoconstriction in the systemic circulation increases vascular resistance, which would enhance the pressure in the blood vessels, weakening the fibrous cup in the endothelial wall and increasing the likelihood of blood vessel rupture. When the plaque ruptures, it exposes thrombogenic material such as collagen and tissue factor to the circulating blood. When a plaque ruptures, it exposes thrombogenic material such as collagen to circulating blood, which activates platelets to adhere to the exposed surface. These platelets become activated, aggregate, and work with clotting factors to initiate fibrin formation, leading to thrombus formation. A thrombus or blood clot can obstruct blood vessels, causing ischemia or tissue damage, which is why anticoagulants are given to avoid further clotting. These medications, however, have a tendency to increase the risk of bleeding. So, as a nurse, it should be a responsibility to remember that invasive procedures such as intramuscular or IM injections are avoided to prevent trauma that could cause internal bleeding. Moving on, the resulting thrombus can partially or completely occlude the coronary artery, restricting blood flow to the myocardium. This further reduces blood flow and oxygen delivery to the myocardial tissue, causing ischemia. As a result of ischemia, there is an increased creatinine kinase MB and troponin I. With the continuation of oxygen deprivation, the hypoperfused myocardium transitions into anaerobic metabolism that leads to the production of lactic acid and thus results in acidosis. Acidic pH further enhances cellular damage that consequently causes the death of cardiomyocytes. This cellular damage is pro-inflammatory because immune cells identify the existence of damage-associated molecular patterns that are recognized by pattern recognition receptors. There is an increased C-reactive protein with inflammation resurfacing. The immune response activates the complement system, a series of proteins that makes antibodies and immune cells more effective at destroying pathogens and damaged cells. Activation of the immune response also leads to the production of the reactive oxygen species, or the ROS, which are highly reactive molecules capable of destroying invading pathogens and of promoting cell signaling. The immune response also activates inflammasomes, which are multi-protein complexes that process and activate pro-inflammatory cytokines such as interleukins, thereby amplifying the inflammatory response to effectively control infection or injury. The release of these cytokines amplifies inflammation, further increasing tissue damage. As the damage continues, the injured myocardium develops infarcted tissue, which is eventually replaced by scar tissue through the process of fibrosis. Scar formation in the myocardium has significant downstream effects that impair the heart's structure and function. The process begins with impaired myocardial elasticity, as the fibrotic scar tissue reduces the heart's ability to relax during diastole and contract during systole. This leads to impaired diastolic relaxation and systolic contraction, which can disrupt the heart's electrical conduction system and predispose the patient to arrhythmias, potentially requiring the insertion of a biventricular pacemaker to restore synchronized cardiac function. Additionally, scar tissue promotes excessive fibrosis, causing the myocardium to stiffen. This stiffness decreases the heart's ability to contract and relax efficiently, leading to dysfunctional diastolic pressure. As a result, left ventricular filling is impaired, reducing cardiac output and causing decreased tissue perfusion, and the backlog of blood further increases systemic venous pressure, exacerbating venous congestion and symptoms of heart failure. These are evidenced by systemic fluid accumulation and portal hypertension. In portal hypertension, there is increased alanine aminotransferase and aspartate aminotransferase because portal hypertension increases liver pressure and can lead to liver damage, causing the release of ALT and AST into the bloodstream, reflecting hepatocellular injury or inflammation. Systemic fluid accumulation then presents as ascites, weight gain, and peripheral edema, as too much fluids lead to third space fluid shifting. This happens when fluid moves from the blood vessels into the interstitial space or the non-functional area between cells. As a treatment, doctors prescribe diuretics to remove excess fluids, and as nurses, the nursing responsibilities are to monitor weight daily, to check for aggravated or resolved fluid shifts while limiting fluids and adhering to a low-salt, low-fat diet that reduces water retention and prevents excess caloric intake, promoting better weight control. In decreased tissue perfusion, blood that carries oxygen fails to reach the extremities, manifesting as activity intolerance, dyspnea, and cold extremities. Nurses encourage ambulation as tolerated for cold extremities to improve circulation and promote blood flow, which helps warm the affected areas. For activity intolerance, clustering care reduces energy expenditure by minimizing frequent interruptions, while placing patients with dyspnea in an orthopneic position optimizes lung expansion, making breathing easier. Finally, dysfunctional ventricular remodeling occurs as the non-infarcted myocardium compensates for the damaged areas. This compensation leads to tachycardia as the heart attempts to maintain adequate output and promotes ventricular hypertrophy and cardiomegaly as the myocardium thickens and enlarges in response to increased workload. With tachycardia, doctors prescribe a selective beta blocker because it blocks specific beta receptors in the heart, reducing heart rate and workload while minimizing side effects on other organs. Impaired left ventricular filling and the stiffening of the myocardium due to scarring lead to reduced heart efficiency in both diastolic relaxation or the filling and systolic contraction or the pumping. The compensatory hypertrophy of the non-infarcted myocardium can initially help maintain output, but over time, this adaptation becomes insufficient, resulting in decreased cardiac output. A decrease in cardiac output triggers the renin-angiotensin-aldosterone system or the RAAS, which compensates by increasing sodium and water retention, leading to increased serum sodium and decreased potassium. This, in return, causes vasoconstriction to try to maintain blood pressure, but the angiotensin-converting enzyme inhibitors are used to block this compensatory mechanism, helping to reduce vasoconstriction and fluid overload, thereby easing the strain on the heart. Chronic decreased cardiac output from impaired myocardial function contributes to ischemic cardiomyopathy, a condition that results from chronically reduced blood flow to the heart muscle or the myocardium, and, if left untreated, progresses into heart failure. In response to heart failure, the body releases B-type natriuretic peptide or the BNP as a marker of increased ventricular stretch and fluid retention with elevated levels indicating worsening heart failure.